name my presentation as common presentations but with differential diagnosis. Because I think as practitioners, seeing kids is a challenge. And when it comes to seeing kids with behavioral or mental illness, or may I say mental issues, it becomes an even more challenge. So sometimes the difficult factor is some of these presentations are quite similar. So they come with the same symptom. But if you look deeply, the diagnosis would be different. So today, during this half an hour, my aim is just to try and sensitize you to this notion of different presentations. So maybe when you see the patient, you would think twice. Am I being deceived by this presentation, or is there something more to what I see? Right. Just before embarking on the main topic, I thought I'll touch a little bit on the national prevalence. Very few studies have been done in our country regarding child mental health, and more credit goes to Professor Hema Mali, my trainer. So if you would see that the main causes of morbidity and mortality in the between the ages of 15 to 24 years age group are suicide, self-inflicted injuries, and poisoning. Quite an alarming story there. And the second bullet point says that 18.9% of adolescents report definitive and severe emotional, concentrational, behavioral, and relationship difficulties. 44% had experienced more than 5 adverse events in the past 4 months. Mental health problems reported in 42% of urban preschool children. It was severe in close to 10%. The school readiness, one of the main topics that's discussed quite a lot. So 17.8 of the 5-year-olds at school entry did not show the characteristics of basically very simple category laid down by the NIE, National Institute of Education. 17.8 did not fulfill criteria required for entry to school. Prevalence of autism, another much talked about topic, was 1 in 93. But the incidence has staggered very high now. And externalizing behavior problems in preschool children had been 19.2. So the big question, what is normal behavior? I don't think anyone out there would be able to say this amount of behavior is normal while the rest is abnormal. I think these 6 pictures show behaviors, activities that are carried out with kids. Some of it, if it's given the right amount, right severity, right context, would be considered as normal. But just again, taking it in exaggeration, or the amount or the context being not right, can it be taken as abnormal as well? So if it is normal or abnormal, who is going to draw the limit? Where should we benchmark ourselves to decide, here I'm going to have this kid, I'm going to treat, but this kid I'm not. So during these few lectures, I'll try to probably sensitize you to some identification to think what is normal and abnormal. Right, so one single slide to say the finer things that we should see when we are thinking about normal and abnormality. If there are behaviors which are quite intensive, or which are persistent, or which are burdensome, and remember the last bullet point, which has the main impact, which has an adverse impact, either emotionally, functionally, on the child, and it should be on the family. It can be the peers in school, the teachers, or anyone. Then we have a right to think that this is an abnormal behavior. So if I go back, the symptoms have to be intense, persistent, burdensome, but with an impact. So if I give you a small example to make this clear. if we have a child who may be a 10, 11-year-old, while walking on the road, he has a tendency to tap on all the lampposts while he's walking. So he likes to do that to get to school. He taps on all the lampposts, get to school on time, does his schoolwork, nobody's bothered. But let's say there's another boy who taps on the lampposts, but while doing that, if he hears the hooting of a vehicle, he has to stop it and start from the beginning again. So he goes back and starts tapping again, but never reaches school on time. Now it's sort of the same symptom, but the impact is quite different. So that's where we decide the first kid didn't have an impact, while the second one had an impact. Now I think it's clear for you to decide who we should treat. Okay, so it's the impact that we would always think of. The impact shouldn't only be for the child. It can be the next door child, maybe the child who's sitting next door who gets eternally disturbed because of this child's fidgetiness. Maybe it's the teacher who has to put an extra hour to work with the child. Maybe the disharmony in the family which is causing these issues. So then there is an impact that we should consider about. Okay, another thing that's of importance is children are growing beings. So they are in a developmental trajectory. So one symptom that is of normal at one age might become abnormal at the next. Very simple thing, I think all of you would have come across, kids who's wetting the bed. So if a mother comes concerned and saying, my kid is 3 years, he's wetting the bed at night. So then we have to think twice. Is this normal or not? Because guidelines say you can go on till 5, 6 years. But if there's another same girl who's coming at 9 years, who's wetting the bed, then we have the concern, right? There again, taking a symptom at different developmental stages is of very, very much importance when we are thinking about presentations for kids. Okay, the next slide, just to highlight that most of the issues and most of the mental illnesses that we see in adulthood has its origin either from birth or more of them in childhood. So a cautious a note that I would like to put in is prevention, where things can be prevented and the adulthood mental illness can be reduced. Most of them, especially the attachment disorders, the pervasive developmental disorders, that's like autism, starts right from birth. But it's just the psychotic illness and substance users which comes later. But again, still coming in the realm of child and adolescents. So if we are able to prevent some of these, the next generation can be actually saved from most of the mental issues. Right. So if we have a child, how do we consider whether this is the problem with the child or is there anything else that's adding up to this issue? So this child who is part of a system can't be considered as a single being. He has a parent, he has siblings, and an extended family who's living with them. So are these presentation an interaction or a dysfunction with the immediate family? Or still more, are the teachers, neighbors, or the peers paying some amount of influence to this presentation? Even further, there is religious settings, the media, parents' workplace, and the sociocultural beliefs, which sometimes gives rise to some of these symptoms, which makes it very important for us to consider all of these areas. So the nucleus might be the child, but the perimetry is the cause. So think about the perimetry and not only about the child. Okay, I thought I'll do this in sort of interesting way. I think it's interesting. So I thought I'll choose some of the most common presentations and then go along to think, which is my second part of the topic, which is the different diagnosis. So the first item I thought would be talking about inattention. So if someone comes with inattention, a common presentation to the clinic setting now. And let's say if they had these other symptoms as well. They are easily distracted, prone to daydreaming, difficulty in completing homework assignments, frequently losing things, common complaints from parents. Does anyone know what we are talking about? What is the common presentation? What do we commonly diagnose this with? The common diagnosis is the ADHD, but the inattentive type, right? Very easy. But remember, at the back, there can be other diagnoses as well. So, should we run and give this diagnosis? Because there can be other causes, right? So, we'll have a look about what other possibilities can happen. Okay, next possibility, learning disorder. One of the main other items where we had seen children to have inattentiveness is when they are having a learning disorder. It could be a global one or even a specific learning disorder. So it's quoted that 50% of children who have learning disability have inattention. So maybe we should spend some time, check the school books, maybe take teachers' comments, and even at the table we can do a simple task. Give some arithmetic, get the child to write something. Then you would be probably able to get some idea. I'm just saying that there is a difficulty of assessing scholastic abilities in our country because we don't have standardized tools. But the easiest method is go on web. The National Institute of Education has all the textbooks. So if you see the textbook and you're able to see whether the grade appropriate work can be done by the child, that's good enough. So if you're sitting in a class and they're teaching French and you don't understand anything, it's no reason that it's definitely you will not be listening. So this is what's happening to this child. If he doesn't understand, loses interest, but he's thought he's inattentive. So make it a point to think about the other possibilities. Another one, the anxious child. Children who are very anxious sometimes can present as inattentive, right? Many of the symptoms of anxiety look like ADHD. Remember, they look like ADHD. So they have difficulty concentrating because they are in eternal fear. Something's going to happen. So they are more preoccupied about checking the surrounding. They're jumpy. They're not sure whether there's something threatening. So they can be aggressive and irritable as well. So the other possibility we are talking about is the anxious child. Well, there is more. Right, obsessive compulsive disorder. Another one of those things which distracts kids and make them inattentive is obsessive compulsive disorder. These thoughts are so repeated, they are intrusive. They keep on coming into the child. And so a child who's having this can't pay attention to what the teacher is teaching because these thoughts are so powerful, and sometimes these thoughts are really true to the child. So just before I came, I saw a patient in the clinic who was saying that she was using the Tipex and the Tipex touched her fingertips, and she thinks that if it gets into her mouth, she's going to die. So that increased anxiety of the fear that something is going to happen will prevent her from listening to anyone what the teacher is saying. So remember, if the teacher says the child is vacant, always not in keeping with her, so maybe the child is being interrupted with intrusive thoughts. Okay, going to my second presentation, which is the restricted speech. I think seeing the pictures itself might be telling this whole story, but to add to that, I'll say these kids don't have eye contact, they have stereotypical behavior, they are in their own world, they have abnormal preferences. What are we talking about here? Autism. Yes, that's the common presentation. I'm very happy that if we are able to detect these kids in the primary care setting, because we are seeing massive amounts of kids who are referred, and the early detection and early intervention has shown to be the best options, best prognosis for these kids. So if we are able to pick them up and we are able to identify these kids, that's the way forward. If we start early, the interventions mainly carried out by the parents can bring them to the level that they can be incorporated into normal education. Right, but there are other kids who don't have speech. Who are they? We're talking about an entity called the selective mutism. Maybe some of you all might have seen, or maybe they do present to the GPs very often, because that's the first contact for this, because the parents are bemused by these children who don't talk in school. They're quite okay at home, they are actually chatterboxes at home, but in school they refrain from talking to the teachers or to the peers. They might use gestures, they have great difficulties fitting into social situations, but if a relative comes home, they're free to talk. So again, should we not consider selective mutism if someone comes and reports to us? But remember, the deciding factor is this child has good social communication and good speech while at home, which is in contrast to the first presentation, the autistic child. Right, let's consider other possibilities as well. A cheerful child, if you can see that picture. Right, let's see what's happening with her. This little girl has a global developmental delay. Again, having a speech delay, coming with a concerned parent who's waiting for this child to speak but not speaking, so brought to the clinic. But remember, she would have other features. She might have had a stormy neonatal period. That's not a must. It might have been there. Other milestones also could have been delayed. But remember, the third point is the important, the salient one. Her social relationships will be appropriate for the developmental age. Right? So, unlike the other kids, again, though the speech is delayed, here is what we have to look for. Is she able to communicate socially with peers of her age, or maybe a little less because her developmental age would be a slight bit lower. Okay. Third point, irritability in adolescents. I think quite a few of them present to clinics and quite well described. So easily gets into arguments with the parents. So is this something to do with the hormones, the changing adolescence? Is that what we are seeing? They have missed homework, does not enjoy previously enjoyed tasks, and withdrawn. Any guesses what we are talking about here? Right, it's a tough one. Irritability is the presentation mostly for teenage depression. They will not have predominant mood symptoms, remember. They might not come and say they are sad, but a well-noticed symptom is the irritability. Very clearly explained by the parents, my kid was not like this. Okay, so remember, teenage depression, we can't miss this. Right, but there are other things that present in the same manner. So, few other things. Yes, substance misuse. Substance use disorders have been coming up quite frequently in our clinic settings now. We have referrals from school sometimes, the whole class, where the teacher finds a mysterious drug or a tablet among the kids. None of them know what it's been used for, so they are rushed to hospital. Right? So they can have the same things. So be vigilant. See what activities are carried out with the friends. Are they missing schools? Is there truancy? Are they normal in between the periods? Are they still irritable, but then there are lots of periods that they are quite normal? Look for the smells, burns, or equipment, maybe papers, foil papers, things that they have been using for the use of the substances. Right. There's another possibility. This is quite rare, but I think if there is the irritable teenager, remember, we can't miss this diagnosis. This is the psychotic illnesses. This is the first time, the early period of adolescence, where the first features of psychotic illness can appear. So if we disregard, because they will not have the full-blown bizarre activities like an adult psychotic person might have, but they might be withdrawn. They might have disordered thinking. There can be self-neglect. The bubbly boy who was there at home has been withdrawn now. But if you have time, talk and see, there might be thoughts that are bizarre. So remember the next possibility of the psychotic illness. Right, I thought I'll put hyperactivity, which should be talked of. If I'm talking about child psychiatry, I don't think I can go without talking about hyperactivity. Right, so I think everybody is familiar with these things. They are always on the go, fidgety, inability to wait for his turn. This is an onset since childhood. If the presentation is still late, but still, if you ask retrospective history, the parents would be able to give some details. Yes, he was like this. Comparative to the brother, he was always on the go. And there's disinhibited behavior. It's not frightened to talk to the stranger next door. He goes to temple, but he can't stay in one place. You find him talking to a total stranger. So this is hyperactivity. So I think again the diagnosis is quite clear, but here this is ADHD, hyperactivity and impulsive type. Another subgroup of ADHD. Okay, so the ADHD, hyperactive, impulsive subgroup. Initially we talked about the inattentive subgroup. But hyperactivity presentation, it's very easy to jump into the conclusion, okay, this is ADHD, but there are other possibilities as well. Okay, first one, an adjustment disorder. Kids adjust to situations with symptoms that mimic hyperactivity. Right? So look whether these symptoms have been of recent onset. And could there be sleep disturbances, crying, irritable episodes, and deteriorations in school activities. So these can be features that mimic hyperactivity, but the catch here is they are of recent onset. So the mother wouldn't be able to say, my child at 3 years was also similar like this. He was always on the go. No, he was a calm, a peaceful child, but now presenting with these symptoms because there had been a stressor or maybe a change in his lifestyle. Okay, let's look for the next possibility, which is a common error that's been done. We see lots of referrals coming with this error where we think kids who have a diagnosis of autism but presenting as hyperactive. Now there can be two reasons why children with autism can present as hyperactivity. In autism, it's like a jigsaw puzzle. Part of autism can be the hyperactivity. So inherently, the autism itself has a part of hyperactivity. But again, they can also have a comorbid hyperactive disorder. So initially, in the past, we were not able to diagnose a child who's autistic with a hyperactive disorder. Now it has been changed. We can have a dual diagnosis. A child who's hyperactive, a child who's diagnosed with autism can have a comorbid hyperactivity as well. Right, my last symptom I'm talking about, bedwetting. I think it's one of the common presentations, so you would know what the symptoms are. So they would be dry by day, but they could have never attained dryness, or maybe they have had dryness for short periods, but there's no fecal incontinence and the age is above 5 years. Right, so common, well-known diagnosis there, it's nocturnal enuresis. Okay, let's see whether there are other possibilities as well. Right, if they're present, remember to exclude a UTI, the first presentation, the first thing in mind. But could this be nocturnal fits? The child is having fits only at night. and so he is wetting the bed. These are remote possibilities. I'm not saying that they are common, but remember, if they are at the back of our mind, we will always consider this. Next one, diabetes insipidus. So flaws if we have not actually diagnosed, so maybe it's best to keep these things in mind. But the thing that's frightening that we should not miss is children who start to bedwet following a stressful incident. Maybe this is the first telltale sign of a sexual abuse, a physical harassment that the child has gone through. So maybe this presentation, and you're the first contact point who probably has to take steps to safeguard this child's life. Okay, I'll just touch briefly on management. Because it's in length. I've talked about many presentations, so I will not go into detail, but in managing issues with children and maybe with adolescents, as I showed in the first, I think the diagram where the child is in the center with the perimetry, we cannot only address the issues of a single child. So we have to address the context issues. This is like a cot mobile. One has become dysfunctional, so the rest of the mobile is sort of trying to mobilize themselves. So we have to think about the others as well. So check the family dynamics. How does this family function? Are these parts of things that's leading to this behavior because of this family dysfunction? Sometimes, if the things that we see are the normal, reassurance is only that's needed. But we have to be pretty sure that we are not missing something. But maybe at your level, if you are confident, oh, this is it. So reassurance, that's all that's needed. But let's say if there is concern, a doubt, maybe then that's where we do the referral. Again, what's very important is here the second family, the second home for this child is school. So we can't forget the things that are happening in school. Just as we are considering the family as one context, the second context we have to think about is working with school. Few behavior techniques can be carried out at a GP setting. Relaxation training, training parents for reverb systems, maybe making timetables, certain very, very simple things that have shown very much of a benefit for managing children with behavioral issues. I think I can stop there because I don't want to go into detail, but I'm happy to answer any questions if there is.